Finals SAQ63 Poisoning. A. Outline the general principles in the management of poisoning by oral ingestion. This is a medical emergency. I would call for help and would assess and manage the patient simultaneously following an ABCDE approach. History is often unreliable or unavailable. An agent-blind resuscitation approach is preferable. Airway. Provide oxygen 15 liters per minute via non-rebreather bag. Intubate and ventilate if unable to maintain airway due to reduced consciousness. If required, non-depolarizing paralytic is preferred to depolarizing paralytic if there is risk of hyperkalemia. Breathing. Monitor continuous oxygen saturations and EtCO2. Assess ventilatory adequacy and signs of respiratory distress and auscultate the chest. Ensure adequate oxygenation and ventilation. Beware intubating a patient with severe metabolic acidosis and compensatory respi alkalosis, as intubation without the ability to maintain adequate minute ventilation may result in CVS collapse, such as in severe salicylate poisoning. Cardiovascular. Large bore IV access. Monitor ECG, NIBP, and intra-arterial BP. Hypotension can be treated with IV crystalloids and vasopressors. Asystole is treated according to ACLS guidelines. Bradycardia, along with other ECG and lab findings, may suggest underlying cause and treatment options. Possible causes for bradycardia includes alpha-2 agonist, beta blocker, calcium channel blocker, digoxin and organophosphate poisoning. Tachycardia is differentiated by rhythm and interval normality. Monomorphic white complex tachycardia is often due to sodium channel blockade. Treatment is with IV sodium bicarbonate. Polymorphic white complex tachycardia is often treated with IV magnesium. Narrow complex tachycardia with hypertension is often due to sympathomimetics or cholinergic drugs. D. Monitor GCS and blood glucose. Patients with depressed level of consciousness of unknown origin should be given 50% glucose IV, thiamine 100 mg IV, naloxone 0.2 to 2 mg IV, especially with findings of meiosis and respi depression. Flumazenil is not recommended. Maintain inline cervical spine immobilization and lock roll precautions if occult trauma is suspected. Exposure. Ensure adequate safety of patient and staff by following proper decontamination procedures. Undress the patient for full examination and decontamination. History and examination. Ascertain the likely poison, quantity ingested, and whether taken with alcohol. Attempt to establish likely interval between ingestion and presentation. Identify the form of drug involved, regular or sustained release, and chronicity of use. Ascertain comorbidities and other regular medications that may cause interactions. Follow changes over time with regards to vital signs, neurological function, level of consciousness, pupillary reactivity, ocular movements, bowel sounds, and motor responses. This helps in identifying toxidromes. Investigations to order includes arterial blood gas. ABG helps detect hypoxemia, hypercarbia, and acid-base disorders, and guides ventilation, resuscitation, and repletion efforts. In combination with electrolytes, raised and ion gap acidosis may be diagnosed. Other investigations to consider includes full blood count, urea electrolytes and serum osmolarity, detection of an osmolar gap by comparison of measured osmolality with calculated osmolality can help indicate the presence of methanol, ethanol, ethylene glycol, acetone, or isopropyl alcohol intoxication. Electrolyte abnormalities should be corrected due to increased risk of arrhythmias. Liver function tests may be deranged in alcohol or paracetamol overdose. Blood glucose and coagulation studies should be ordered. CK may be elevated in rhabdomyolysis. Serum and urine toxicology screen can help direct specific therapies in selected cases. In many hospitals, a basic serum toxicology screen includes levels of paracetamol, salicylate, and volatile alcohols. Although cyclic antidepressant levels may confirm antidepressant ingestion, they correlate poorly with toxicity. Some hospitals have comprehensive blood or urine toxicology testing that can isolate many obscure compounds. However, the results of these tests often become available long after the window for appropriate treatment. Urine toxicology screen report only the presence or absence of a substance and are limited to a small number of drug groups. Qualitative screens have minimal or no impact on the initial management of poisoned patients. Cross-reactivity with particular assays may lead to false positives. Treating patients on the basis of their clinical status rather than their test results is often the safest plan. Urinalysis may reveal several findings. CAS suggests acute tubular necrosis from intrinsic renal damage. Positive hemoglobin screen without presence of RBC suggests rhabdomyolysis. Oxalate crystals suggest ethylene glycol poisoning. Fluorescence under a wood lamp suggests antifreeze ingestion. Chest radiograph may reveal pulmonary edema due to salicylate or opioid poisoning. Abdominal radiograph may be considered in suspected body packing. Expert advice from ToxBase or National Poisons Information Service should be obtained with regards to measures to reduce absorption, increase elimination, or for roles of specific antidotes. GI decontamination may reduce the absorption of orally ingested poisons. Options include gastric emptying procedures such as induced emesis and gastric lavage, adsorption of drugs via activated charcoal, single dose or multi-dose, and whole bowel irrigation or cathartics to increase the rate of transit through the GI tract. All these methods lack evidence of efficacy. Drugs that may be adsorbed to activated charcoal includes the killer Cs, cyanide, colchicine, calcium channel blockers, cyclic antidepressants, cardiac glycosides, cyclopeptide mushrooms, cocaine, sisutoxin, and salicylates. A mnemonic to help remember drugs that do not adsorb to charcoal is PHAILS files, P for pesticides, H for heavy metals, A for acids, alkalis or alcohols, I for iron, L for lithium, and S for solvents. A mnemonic to help remember substances amenable to multi-dose activated charcoal is ABCDQ, where A stands for aminophylline, B stands for barbiturates, C for carbamazepine or concretion-forming drugs such as salicylates, D for dapsone, Q for quinine. Methods to increase toxin elimination includes alkaline diuresis, hemodialysis, and intravenous lipid emulsion therapy. Alkaline diuresis is effective in enhancing the elimination of barbiturates, primidone, and salicylates, but may induce hypokalemia. Acidification of urine is not recommended. A mnemonic to help remember dialysable toxins is plasma TV, P for phenobarbital, phenytoin or paracetamol, L for lithium, A for acidosis, S for salicylates, M for metformin, A for alcohols or amphetamine, T for thiophyllene or thiocyanate, V for valproate. A mnemonic to help remember drugs that may be treated with IV lipid emulsion is LAPC, L for local anesthetic, A for antidepressants, B for beta blockers, and C for calcium channel blockers. This table shows the specific antidote for various toxins: N-acetylcysteine for acetaminophen toxicity, benzodiazepines for amphetamine, dimercaprol for arsenic, mercury, gold, or lead poisoning, glucagon, calcium, and pacing for beta blocker toxicity, benzodiazepines for bath salts, flumazenil for benzodiazepines, calcium, glucagon, pacing, and insulin for calcium channel blocker toxicity, 100% oxygen or hyperbaric oxygen for carbon monoxide poisoning, benzodiazepines for cocaine, vitamin K for coumarin derivatives, nitrites, thiosulfate, or hydroxycobalamin for cyanide toxicity, blood alkalization for cyclic antidepressant toxicity, digoxin-specific FAB for digoxin toxicity, ethanol and fomepizole for ethylene glycol, protamine for heparin, deferoxamine for iron, pyridoxine for isoniazid, hemodialysis for lithium, ethanol and fomepizole for methanol poisoning, naloxone to reverse narcotic poisoning, methylene blue for nitrites, glucose and octreotide for oral hypoglycemic agents or insulin, atropine and pralidoxime for organophosphate poisoning, urine alkalization and hemodialysis for salicylate poisoning, benzodiazepine for synthetic cannabinoids, and multi-dose charcoal and hemoperfusion for thiophylline toxicity. Liaise with ICU team for ICU admission if warranted. General criteria for ICU admission includes PaCO2 of more than 45 mmHg, need for intubation, post-ingestion seizures, unresponsive to verbal stimuli, non-sinus cardiac rhythm, second or third degree AV block, SBP less than 80 mmHg, QRS more than 0.12 seconds, age greater than 60 years old, abnormal body temperature and suicidal intent. B. What are the mechanisms of toxicity of TCA overdose? This includes presynaptic noradrenaline and serotonin reuptake inhibition, leading to therapeutic antidepressant effects, early sympatomimesis, myoclonus and hyperreflexia. Fast sodium channel blockade leads to cardiac depression, reduced cardiac output, hypotension, ECG changes, and seizures. Potassium channel efflux blockade leads to QTc prolongation. Muscarinic acetylcholine receptor blockade leads to tachycardia, hypotension, irritability, mydriasis, confusion, seizures, coma, ileus, urinary retention, reduced sweating and pyrexia. Histamine receptor blockade leads to sedation. Alpha-adrenergic receptor blockade causes sedation, hypotension, meiosis and reflex tachycardia. GABA-A receptor blockade causes seizures. C. List the clinical features of a TCA overdose and how the associated life-threatening complications are managed. Respiratory depression, hypoxemia, reduced consciousness and coma is treated with intubation and ventilation. Acidosis and prolonged QRS is treated with sodium bicarbonate. Sodium bicarbonate increases sodium levels to compete with sodium channel blockade. It alkalizes blood to reduce affinity of TCA to sodium channel. Dose is 1 to 2 MEq per kg with a target blood pH of 7.45 to 7.55. Hypertonic saline can be considered if the patient continues to have QRS prolongation or with significant right axis deviation despite alkalemia. Enteral potassium is monitored regularly to prevent hypo or hyperkalemia. Arrhythmias such as intraventricular conduction delays, white complex arrhythmias and prolonged QRS can be treated with magnesium, lidocaine, phenytoin and synchronous cardioversion. Correct hypoxia, electrolyte abnormalities, hypotension and acidosis. Hypotension can be treated with IV fluid boluses, vasopressors such as alpha agonists, and glucagon. Cardiac arrest is treated as per ALS guided resuscitation. Seizures is treated with benzodiazepines and anesthesia. Pyrexia is treated with cooling measures. Life-threatening adverse neurological and cardiac symptoms resistant to other treatments is treated with intralipid, hypertonic saline and ECMO. Activated charcoal may reduce absorption of TCAs, hence reduce all adverse effects. Overall, 65% pass rate. Additional Q&A. What are the most common causes of poisoning in adults? This includes analgesics 11%, sedatives, hypnotics and antipsychotics 10%, antidepressants 6%, CVS drugs 6%, cleaning substances 5%, alcohols 4%, anticonvulsants 3%, pesticides 3%, envenomations 3%, and antihistamines 3%. What are the most common causes of poison-associated deaths in adults? This includes miscellaneous sedatives 13%, CVS drugs 13%, opiates 7%, stimulants and street drugs 7%, alcohols 5%, paracetamol alone 5%, paracetamol combinations 4%, SSRIs 3%, fumes, gases and vapors 2%, and antidepressants 2%. Should intentional poisonings be assumed a priori to have greater chance of serious harm? Yes, while only 1% of poisonings result in major effect and 0.07% of poisonings result in death, intentional poisonings are 32-fold more likely to result in major or fatal effects. What is a toxidrome and name some examples? Toxidromes are physiologic syndromes associated with classes of toxins. They may be useful in making the diagnosis of poisoning and initiating treatment. Examples of toxidrome include cholinergic toxidrome due to organophosphate and carbamate insecticides, Amanita muscaria and nicotine, anticholinergic toxidrome due to atropine, benztropine, scopolamine or diphenhydramine, sympathomimetic toxidrome due to cocaine, methamphetamine and MDMA, sympatholytic toxidrome, for example, due to clonidine, methadopa and oxymetazoline, opioid toxidrome, such as due to heroin, morphine and fentanyl, serotonin syndrome, such as due to SSRIs, tramadol and meperidine, and neuroleptic malignant syndrome, such as that caused by haloperidol, chlorpromazine, promethazine, and quetiapine. A mnemonic to help remember muscarinic symptoms in cholinergic toxidrome is dumbbells, D for diarrhea, diaphoresis, U for urination, M for meiosis, B for bradycardia, E for emesis, L for lacrimation, lethargy, and S for salivation. Nicotinic symptoms may be remembered by days of the week, M for mydriasis, T for tachycardia, W for weakness, T for tremors, F for fasciculations, S for seizures, and S for somnolent. Patients with anticholinergic toxidrome are blind as a bat, mad as a hatter, red as a beet, hot as a hair, dry as a bone, and full as a flask. How do vital signs provide clues in diagnosing the ingested toxin? The following are mnemonics to help remember drugs that cause variations in vital signs. CT scan for hypertension, C for cocaine, T for thyroid supplements, S for sympathomimetics, C for cannabinoids or caffeine, A for anticholinergics or amphetamine, and N for nicotine. Crash causes hypotension, C for clonidine, calcium channel blockers or cyanide, R for rodendoside, which may contain arsenic or cyanide, A for antidepressants, aminophylline, antihypertensives, alcohol, and anticholinesterase, S for sedative or hypnotics, and H for heroin or other opioids. Fast C causes tachycardia, where F stands for freebase or other forms of cocaine, freon, A for anticholinergics, antihistamines, antipsychotics, amphetamines and alcohol withdrawal, S for sympathomimetics, solvent abuse, strychnine, and synthetic cannabinoids, T for theophylline, tricyclic antidepressants and thyroid hormones, and C for carbon monoxide and cyanide. PACE drugs causes bradycardia, where P stands for propranolol, poppies, i.e. opioids, propoxyphene, physostigmine, and propofol. A stands for anticholinesterase drugs and antiarrhythmics, C for clonidine and calcium channel blockers, E for ethanol or other alcohols, and D for digoxin. PANT drugs causes tachypnea, where P stands for PCP, paraquat or phosgene, A for acetylsalicylic acid, amphetamine and anticholinergics, N for non-cardiogenic pulmonary edema and nerve agents, and T for toxin-induced metabolic acidosis and theophylline. SLOW drugs causes bradypnea, where S stands for sedatives, L for liquor, i.e. alcohols, O for opioids, and W for weed, i.e. marijuana. NASA drugs causes hyperthermia, where N stands for neuroleptic malignant syndrome, nicotine, A for antihistamines, alcohol withdrawal, and amphetamines, S for salicylates, sympathomimetics, and serotonin syndrome, and A for anticholinergics, antidepressants, and antipsychotics. Other drugs that may cause hyperthermia include theophylline, cocaine, and beta blockers. Drugs that cause hypothermia include COOLS, C for carbon monoxide, O for opioids, oral hypoglycemic agents and insulin, L for liquor, i.e. alcohols, and S for sedatives. How do neurological signs provide clues in diagnosing the ingested toxin? Important neurological signs include pupillary signs, nystagmus, seizures, and coma. Drugs that can cause pinpoint pupils are COPS, C for cholinergic drugs, clonidine and carbamates, O for opioids, P for phenothiazines, pilocarpine, phencyclidine and pontine hemorrhage, and S for sedatives. Drugs that can cause pupillary dilation include sympathomimetics, anticholinergics and withdrawal syndromes, SAW. Other drugs that cause mydriasis include alcohol, antihistamines, barbiturates, ethanol, betadine, and phenytoin. Drugs that may cause nystagmus include alcohol, carbamazepine, carbon dioxide, phencyclidine, phenytoin, and sedatives. Drugs that cause seizures include Otis Campbell, where O stands for organophosphates or oral hypoglycemics, T for tricyclic antidepressants and theophylline, I for isoniazid and insulin, S for sympathomimetic, strychnine and salicylates, C for camphor, cocaine, carbon monoxide, cyanide, and chlorinated hydrocarbons, A for amphetamines and anticholinergics, M for methylxanthines such as theophylline and caffeine and methanol, P for phencyclidine, propranolol, and phenothiazine, B for benzodiazepine withdrawal, botanicals, bupropion and GHB, E for ethanol withdrawal and ethylene glycol, and L for lithium, lidocaine, lead, and lindane. Drugs that can cause coma may be remembered by the mnemonic lethargic, where L stands for lead or lithium, E for ethanol, ethylene glycol, T for tricyclic antidepressants, Thallium and toluene, H for heroin, hemlock, hepatic encephalopathy, heavy metals, hydrogen sulfide, and hypoglycemics, A for arsenic, antidepressants, anticonvulsants, antipsychotics, and antihistamines, R for rohypnol and risperidone, G for gamma hydroxybutyrate, I for isoniazid and insulin, and C for carbon monoxide, cyanide, and clonidine. How can one quickly identify many tricyclic antidepressants by name? The name of many TCAs end with tryptyline or ipramine. Others include doxepin, amoxapine, and iprindole. What value is the ECG in patients with TCA poisoning? ECG is the best early screen for TCA toxicity. ECG findings usually manifest within the first few hours of poisoning. Classic ECG findings of TCA poisoning include sinus tachycardia, PR prolongation, widened QRS, QTC prolongation, and terminal R complex in the AVR more than 3 mm in height. ECG features are predictive of the clinical cause and guide treatment in severe toxicity. Prolonged QRS and terminal R complex in AVR more than 3 mm indicates increased risk of seizures. What additional clinical services should be provided to patients with intentional poisonings? These patients should undergo assessment by mental health professionals for assistance and diagnosis and treatment of coexisting mental illness. It is critical to determine eligibility for adjunct care programs and if ingestion is related to physical, mental, or other types of abuse on and or by the patient. These are my references. Thank you.